Hello, everybody. Can you hear me? Sounds pretty good. I wanted to welcome everybody to this, our first DoraMind event. I'm, I'm Brady Richards. I'm the co-founder of DoraMind, along with Mimi Liu, who's sitting there in the back. And I think that what we're hoping to talk about today is perspectives on recovery. And I think when Mimi and I started DoraMind about 2.5 years ago, one of the things we were looking at is we had this shared experience of having younger brothers who had psychotic episodes when they were freshmen in college. And that we got to participate in the process of trying to figure out how to get to a recovered, meaningful life after that. And we thought it was worth being very curious about. That felt pretty hard to us and to our families, and we thought it was worth trying to understand why. And so I think that's at some deep level, we poked around at that question. We came to the conclusion essentially that it was very, very tough but possible. That's sort of the idea behind DoraMind. And so I'm excited to sort of explore the space today. And thanks to everybody who came out, and thanks especially to Kelly for putting this on.
Thanks, everyone. Thanks, Brady. Yay! All right, we're getting started. So thank you, everyone, for coming. Our audience is a mix of SMI curious and also folks with lived experiences. So we'll start off with brief introductions. If I could do the intros for you guys. Okay, sweet. So today on the panel we have Rob, or Dr. Laitman, and Hannah Bock. Rob is the clinical director at DoraMind. He is a marathon runner, founder of Team Daniel, and published author. He's a fierce advocate who applies specialized knowledge, including the optimal use of clozapine, to raise the bar on treatment and family advocacy after navigating the system with his son. Hannah is the associate clinical director at DoraMind. Hannah brings frontline experience from Rikers, Bellevue, and New York City shelters, and leverages her background in tech to build sustainable, innovative support systems for marginalized populations. Okay, so to get started, I was curious what you guys are whispering over there. Could you describe in layperson terms, like what is schizophrenia, bipolar, maybe some triggers, and if prevention is possible, real quick, like 60 seconds.
So, yeah. I don't do anything in 60 seconds. Okay, so really, what she just was alluding to is what we call a spectrum of illnesses, a psychosis spectrum of illnesses. And it encompasses schizophrenia, which is more on the thought disordered end of the spectrum. And then as you move towards schizoaffective, it's thought disordered. In other words, people that just don't sometimes make a lot of sense, have trouble with cognition, have prominent negative symptoms. But as you get to the schizoaffective, there's more of a mood component, and we call that often schizoaffective bipolar type. Then you're moving down the spectrum, and you get to bipolar illness. And that often has a very large mood component. Well, it is a mood component, and it's the up and down. People have seen that. Also part of this spectrum is what a lot of you guys have experienced. Your kid went to college, they started smoking pot, and they were given the diagnosis of psychosis secondary to substance abuse. All of these things go one direction or another. Things are not fixed. Typically, what you'll see is someone over their lifetime not getting appropriate treatment will get more and more of the thought disorder. Those are what the negative symptoms, they just keep accruing over time. As they get intermittently treated, the positive symptoms go up and down, because positive symptoms are often pretty responsive to all the other antipsychotics. Clozapine's the best, but the other antipsychotics usually make a difference. But the other antipsychotics, except maybe the new one, Cobenfy, which we can talk about later, but really doesn't have a role with most people here, doesn't affect the negative symptoms. So what does this spectrum of illness really result in? It results in the detachment from reality that brings the person and the family a lot of suffering. And that's how I define psychosis. Hallucinations are not psychosis. A lot of us will hallucinate. I've had a visual hallucination once. That's not psychotic. Well, some people think I'm a little psychotic, but no, it's really not psychosis. You know, even having overvalued ideas, one of my favorite phrases, almost a fixed false belief. As long as you are in society and functional, that's not psychosis. It's the decline in your status that defines the psychotic disorder and being detached from reality.
Yeah. I think that question's answered.
Oh, come on.
We could segue into treatment. So can you both share your approach to care? So what's at the heart of what you do?
I think good. I think at the heart, closer? Okay. I think at the heart of what I do, at least, is making incremental changes, both in people's lives and in these many broken systems that we all see sort of intersecting each other within severe mental illness. Yeah. I'm more succinct than you are.
Succinct is not part of my approach. Yeah, I mean, look, when Brady and Mimi came to me 3 years, it was a cold call. And why they came to me is because I've been fortunate enough to have remarkable outcomes. And I've been doing this since my son got ill, now going on 20 years ago. You know, what's not typical. In fact, when I first presented my son Daniel to the people up at Harvard, especially this woman, Deborah Levy, she said, "You sure your son has schizophrenia?" And I go, "Why do you say that?" She goes, "Because he's funny." My son, you see, is a stand-up comic. And already before he got ill, had started on that thing. And one of the misconceptions is if you have quote unquote schizophrenia, you can't be funny. So, but getting back to it, so that led us on our journey, because remember, I'm not a psychiatrist, I'm an internist. And I just found it implausible that someone would come to me and tell me my 15-year-old son's life was over. And so last 20 years, I changed the whole focus of my practice to use the most effective treatments in the most effective ways, which is what I'd always done as a nephrologist and a gerontologist. That's what we're taught to do in medicine. I said, you have to do the medicine. You have to, really simple. It's called being kind and being competent. I don't care that it's clozapine. It's just so much more effective. So, you use the best treatments as early as you can in any medical illness. I didn't understand what they were talking about all these years. And yeah, and again, 20 years later, I still am outraged because I was challenged when my son got significantly better and was back doing his comedy. We were told, his life is over. My wife's sole ambition was to keep him from being homeless. Daniel graduated from college with honors, has been living in the city for 10 years, and just August, he got married. So, it's a full life. He's right now sucking off the teat of Tiva and getting paid a few $1,000s just because he and Eric Smith, Tiva is a pharmaceutical company that makes clozapine. One of the initiatives, which I agree with the pharmaceutical companies, is they're starting to realize that meaningful recovery is possible. And so they're approaching people like my son, like this fellow, Eric Smith. I don't know if any of you guys have had any contact with him, someone that Team Daniel works with. He's a gentleman in Texas who had court-mandated treatment, was really very ill, and of course is on clozapine, and is doing well. So, so what's the treatment approach? Just use the best treatments. Involve the parents, involve the family, and provide wraparound services.
Well, I also think there's a lot of room to do this because our systems are our systems are pretty antiquated in general, both for the medicine and the social systems we use to integrate that medicine, right? Specifically within psychosis. And we have this niche because of this sort of lacking within the system, right?
Could you share like a story of one of the families we treat without maybe identifying details and share like what recovery looked like for them, what we did?
Oh, sure. So the last patient that I saw in the office before I flew over to Texas for a meeting was Thursday night. And this is a kid who came to me 6 to 8, I forget. We'll call 7. We'll split the difference. 7 years ago. And the only reason he came to me is because he had developed tardive dyskinesia with the first generation antipsychotic. And I don't even know how he got my name originally. This was a John Nash-like fellow in that he was a PhD candidate who had been at that time working on his PhD for 8 years. He'd been on a first generation antipsychotic. He hadn't been well managed, and he did have the early signs of tardive dyskinesia. He came to me to get what's called a VMAT2 blocker, which is the standard treatment for tardive. And I gave him a proposition since he'd been working so long on his dissertation and had been totally stuck. I said, in the old days, we used to use clozapine as a treatment for TD. And you might get a hidden benefit from actually getting better. Well, he agreed to try that. The TD was really mild. And I eventually switched him off his first generation antipsychotic, put him on clozapine. 2 years later, he finished her dissertation. He got published in a really prestigious math journal. And right now, he is working as a math professor at CUNY, teaching high level, and I don't expect this from all of you guys, but this is just an example of someone who was completely stuck. And as a hidden bonus, we decided to treat the medical side effects. So he came to me weighing 306 pounds, and he's also now down to 180. And he promises me he's going to start to date. That's the next step.
That's awesome.
All right. This isn't as long held the patient, but we have someone at Dora who I actually saw in my private practice previously. He was in and out of the hospital for many, many years after developing psychosis in his late 20s. Significant suicidality, some violence. He had couple car accidents related to the hallucinations. And the family came right after one of their recent hospitalizations to continue his clozapine and his other antipsychotic. At the time, we did the same thing. We sort of cross-tapered to clozapine, and he's with us at Doro now, transitioned from my private practice, and he's looking, first of all, to get his driver's license back. And second of all, to start looking at job programs. So pretty big stuff.
And I just have to do this for Nina. So there's a kid I've taken care of for now 10 years, and he was on, again, an injectable, an LAI, living in a residential center, picking up cigarettes from the street, but not going back and forth to the hospital, but had no interest in anything, no motivation to do anything, barely spoke. And over several years, and also would not take his medicine. So I had to get a court-mandated treatment. So first of all, I had to maintain the court-mandated treatment for 6 years. It took that long. I got him off of the injectable, got him onto clozapine, and then he was stuck. He was just stuck. He was stuck at home. He managed to, get better and better and really socially interacted well. But then the Dora people came in, and this is why I want to give Nina a shout out. I introduced her to him, and they've been working. And this Wednesday, he's starting his dream job. This kid was like a savant with a guitar. and had stopped playing altogether. So he is starting a job, working hopefully not too many hours at the music store. We have to cut it down a little bit and going to be teaching people how to play guitar.
It's awesome.
But it took a long time.
Yeah, thank you for that. And I wanted to ask maybe more specifically, like maybe a little bit about what it's like to be a member of Dora Mind and how you go about treating families or caring for families. Just a little bit, just a little teaser.
Specifically at Dora Mind.
Yes.
I mean, I think the unique thing about both Dr. Laitman and your practice and Dora Mind is we are integrating families, which we know with psychosis and severe mental illness, we see better results, we see recovery when there is family involvement, family being whoever your chosen family is. So I think that is very unique. There are a lot of outpatient programs that say they integrate family in some way. Maybe they do, but usually it's pretty peripheral. So I think that's pretty unique, and trying to ensure and reinforce the family is fully engaged, both in getting their own support and supporting their loved one is a huge part of our practice at Dora Mind.
Yeah, no, I appreciate that. We spent a year with Brady and Mimi before we launched, just going over what the model could be. And I had my prejudices. So our model, which I'm sure anyone who's ever been on any of my Zoom calls knows, it's just the ease model, right? Does everyone know what that means? Oh, let's tell. All right, so E is early use of clozapine. A is just like what Hannah just said, really assertive management. And it doesn't just mean management of the medication and the side effects, but giving those wraparound services, what I like to call recovery services. I always tell these kids, the medicines don't make you well, but they allow your brain to then do the work for you to make yourself well. Then you have to do the work. You have to do the cognitive enhancement training. You have to do the exercise, the diet, and we try to include all of those things as part of our regimen. S, I hate to say it, is slow. So it's a slow titration to minimize side effects. But this whole process is slow. I always tell kids and parents, it's like watching the grass grow. You go, oh, is it a little longer? It's a little better. You need a lot of patience. And then again, to Hannah's major point, and where we're really different, is we never let HIPAA get in our way. And it really wasn't designed to get in the way. If you really know what HIPAA says, it's always meant to be best judgment. I could never dream when I was doing gerontology, not talking to the kids of my clearly, older patients that may have been a little paranoid about their kids. Say, don't talk to Sarah, don't talk to Jeff. They're out to get me. Well, I used best judgment. And for some reason that gets left out. It's like we don't leave that out in Dora Mind. We always use best judgment, and we talk to families. You need engagement. If you're going to do this, if you're going to do our approach, it is not easy, but it's so worthwhile. And, it's I'm not going to tell you it's easy, it's hard. But what's the alternative? All these other drugs are hard, and you just don't get good results. We get great results, not always, but mostly. If you're going to look at the few hundred people we've taken care of, and there's some of them, families in the room right now, everyone responds somewhat. Do they respond to the extent that we want in the first year or two? Probably not, a lot of them. But you keep following them, and the odds get better. And that is distinctly different than all the other antipsychotics where you say, oh, it used to work. Clozapine's the other way around. It works better and better over time.
I just wanted to add on a few statistics. And Mimi and Brady could correct me, but we prevent about 80% of readmissions compared to traditional care, which is kind of like the reverse. Oh, yeah, we're Dr. Laitman. Just shout out some stats.
There we go. I'm back on. There we go. So in the 180 patients, and this is the old data, this is from February of 22, we had 180 people that we followed for at least a year. Of the people that had come into our practice, 93% were hospitalized the year before coming to see us. Since then, only 15% have come to the hospital. This is of 22, so I have to update the data, and there are more patients. And of that 85%, only half of those were for psychiatric admission. Medical admissions happen. One of the risks, and I'll tell you, this is why you have to do the work. This is why you have to do the medicine. Pneumonia does happen. Severe constipation, despite best practices, can happen. And that's where the other 7 admissions came from. Mostly pneumonia, not really. I think I only had one kid, the horrible thing, that had to be manually disinfected in my entire 15 years. And that's because the family couldn't get the medicines into them.
That's great. Yeah, that's great. So, the other 70% achieve meaningful recovery.
That's 70% with the diagnosis of schizophrenia, which is the severest form of the thought disorder. But as you go up the spectrum, if you look at, and again, I really don't like the diagnoses because they blend together. And actually, if you read the DSM-5, you'll say, this is the diagnosis unless they've been given the other diagnosis. Excuse me. And if you look at the genetics, they're almost the same. They really do carry over. But nevertheless, in a less pervasively thought disordered individual, someone with what we call bipolar illness, we've had upwards of 79% into meaningful recovery. And that's defined as 20 hours of meaningful work, running a household, being out into programs, basically being restored to society. That's what we're looking for.
And compared to the untreated, like if you weren't getting treated?
The standard for the best analysis was it 2014 or 2016? I don't remember. 2014. Let's go. What's called a meta-analysis, which is taking all the recovery studies that are out there. In the U.S., it was 14% overall. The best recovery for another nation was New Zealand, which was 33%. But they also had about 30% of their people on clozapine, which in the United States is less than 4% right now. We're number 1 in the world for lack of use, unfortunately. That's part of, the problem.
I guess segueing, that's a good segue. What innovations are you looking forward to in this space, if any?
Well, one of the concrete accomplishments that I'm most proud of is I've been railing about the mandatory blood work for a very long time, and people would just fool me. But I kept going back with the data, and finally, I got enough people's attention, and last November we all testified in front of the FDA. And I did my little scientific thing saying this is ridiculous, all the rest. But what really swayed the FDA is this group that was really derived from Team Daniel Running for Recovery, which is my charity. The angry moms and the mad moms all gathered in Washington and told their stories. And it was, that was a concrete occurrence because they were not ready to get rid of the mandatory blood work. But, even though we told them that, what is the incidence of death with clozapine-induced severe low white count? And when does it happen? And you know what? They didn't know. It was remarkable. They weren't up on the most recent literature. Gopal Weiss, a gentleman from Maryland who I'd sent the article to, and I said, and he was on the committee, he informed everyone else that the real incidence of this horrible complication that terrifies all the psychiatrists in the United States was 0.23%. That means 99.8% of all these kids will never get this. And when do you get it? 90% get it during the first 18 weeks. And yet we were doing these mandatory blood work that really made it almost impossible to use clozapine if you're going to really follow the guidelines. Every week, you have to get a psychotic kid who can barely hold it together for his mandatory blood work. It's nuts. So that's my biggest innovation, is eliminating that. That was huge. That was enormous. But so I'm part of Schizophrenia and Psychosis Action Alliance, and this is where I was in Texas. We also have a group called SPAN because we like acronyms, and that's it's an action network. We formed it because it's a 501c4. I'm telling you stuff you really don't need to know. A C4 can actually lobby. That's why we formed it. A C3, which is what Team Daniel is and what Schizophrenia Action Alliance is a C3. You're not legally allowed to lobby. The TAC, Treatment Advocacy Center, does anyway. But we like to stay in the law. So we're trying. Our big innovations are just getting, reforms. Yeah, have you guys ever heard of the IMD exclusion? Anyone? No?
No.
So that was basically an attempt to close down institutional beds. So it limited the number of beds to any one institution that was treating institution of medical disease to 16 beds. So if you wanted Medicaid support. So it really limited the number of possible beds. And, the states didn't want to pay for it, so they systematically closed down the beds. There were too many beds. In the 1950s, there was over 500,000 psychiatric beds in the United States. Now there's only 50,000. So one of the things we need more beds. You know where all the beds are right now? Chronic beds? They're all in forensic, which means they're people that are trying to be made sane so they can stand trial. That's the very definition of insanity. It's really hard to get someone who needs long-standing treatment in a program that will take them for a long period of time. But we're expanding the beds. That's one of our initiatives. And hopefully it'll work.
That's awesome. And did you want
I was going to say some of the population studies around people who, there are a bunch of population studies usually backed by some AI model around people who may be at risk for psychosis or maybe presenting with certain symptoms that look like early psychosis, and we know the duration of untreated psychosis predicts a lot of response to treatment later on. So I think some of the early research around that is really important. There was, I think the most recent article I saw is that NYP Columbia is doing that research.
There's a woman on Long Island that is identifying kids that have decreased processing speeds. And, as I don't remember who I was having a conversation with, but I was telling you that the most complicated thing that we do is social interaction. It's also the biggest predictor of how kids are going to do. And that needs tremendous processing speed. So if you take these kids with decreased processing speeds, there are things you can do, and that's the cognitive enhancement treatment. These silly little computer programs really work, and they translate out to improve processing speed. Now you have to get the kid to do it, but it's one of the successes. And then you go even further back, and there's ongoing studies that Robert Freeman did from the University of Colorado, looking at at-risk populations, because a lot of our kids that are getting better are not having children. Hard to believe, but that's what's happening, and it's kind of nice. I've seen that. I've actually taken a few kids on clozapine through pregnancies, but we know they're at higher risk for developing psychotic illnesses. But there are things to be done. For instance, the supplementation of high-dose lecithin, which is something called phosphatidylcholine. It gets converted in your body to choline, and that drives the formation of acetylcholine neurotransmitters. And that's really important in terms of prevention for schizophrenia. And what Friedman's already found is we're only at year 6, these kids. So a lot of these kids look normal now, as opposed to when they went back and looked at the films of the kids that were having these children. They had what are called soft neurologic signs. So they were clumsier, like my son Daniel. They didn't walk as fast as their other siblings. They may have talked a little later. They're soft signs, they're not absolute signs. So we'll see. But, doing the right things, getting, this is not political, but getting your vaccination so you avoid intercurrent illnesses is incredibly important. Again, I'm talking in utero because all of these illnesses, I define them as a heterogeneous, which means there's tremendous variety, complex genetics, because there's a million ways to do it, because your brain has, basically, what is it, I think half of the genetic machinery goes into making your brain. There's a lot of genes that interact, and it's neurodevelopmental. So you have to start early. Now, with proper treatment, it's not neurodegenerative, but if you don't do the right things, it tends to be. So that's I think the innovation, the realization you can impact really early, like Hannah just said, and you can impact all the way down. What are the other, what we call epigenetic phenomena? Pot is a huge one. It can increase your risk of developing psychotic illnesses 5-fold. We're starting to identify genes that really put you at higher risk. So that's another innovation. And, over time, we're hoping to integrate all these things together. That's, at least we're trying.
There's a lot going on. That's awesome, especially because I remember when maybe folks first got diagnosed, it's kind of like a death sentence, or that's the stigma around a lot of these illnesses. If there's so I'm going to open up to audience questions now-ish, but after one thing from Dr. Laitman and Hannah. So if there's one thing that you wish our audience can take away, what's that one thing that you would want them to do or remember?
I know I already spoke about this, but family and caregiver involvement, and involvement being also them supporting themselves in whatever way they need to and can, because they have to model that for the individual who's ill, and they have to be able to have the capacity to support them. And I think, I see a lot of families discount their own mental health in favor of their loved ones.
I'm looking at the screen here, and I feel like that's a lineup. What I really want you to come away with is hope. You guys have been given a bill of goods. I was given the same bill of goods, but there is hope. There really is. And I live it every day. I've shown it for a very long time. And what I ask of you guys, and I could probably quiz some of my audience members, what I expect from you, and this is tough, is relentless positivity. Okay? I expect you guys to keep a low emotional temperature, because that actually correlates very nicely with relapse of our kids. There's a family that is sorry, and I know I was myself in the very beginning, how to learn. And then vigilance without being hypervigilant. Those are my 3 things. And actually, let me add one more. Check the guilt at the door. It's no one's fault. This stuff happens. It's amazing that any of us are neurotypical. There's just so much, and some people question me. But there's just so many things that can go awry. And you don't have to convince your kid that they've got schizophrenia or bipolar or whatever you want to call it. You know, if their name is Scott, they've got Scott syndrome. And it's a very treatable syndrome. You just have to do the work, and then you have to cooperate and take the lump sometimes, because it's never linear. I wish it was, but it's never linear. But I want you to come away with that. There's a correct approach. That's all. There's the right way to do things. And all I'm saying is, right, use most effective treatments in the most comprehensive fashion. Again, not rocket science.
All right. Open for audience questions. Any questions from the audience? I'll give this mic to you. And walk around.
Don't be shy, please.
I also have like a list of questions.
Thank you so much. That was super, super insightful and enlightening. Can you expand a little bit more on what makes clozapine more effective than other antipsychotics?
You probably shouldn't have asked me that. Yeah, no, I was asked in the audience, can you give me the mechanism of action of clozapine? You know what? You want me to give you the short answer? We don't know, but I'll tell you what it does do. Okay, let's go one step at a time. It has probably the best effects on what's called dopaminergic signaling. You use dopamine in your brain to identify what is pertinent and real. And in psychosis, that's something called, well, in life, it's called salience. And when you have psychosis, you have false salience. The dopamine's dysregulating, you don't know what's going on. And that's an entire pathway. It works at modulating that. That's step one. Moving back a little bit, it also works on other dopamine receptors. So that's what's called the D2 receptors. There's 5 dopamine receptors. I'll cut it short. But clozapine works on D1, D2, D4. And the D1, D4 are really important in terms of cognition as well. So that's part of the reason it's a better cognitive enhancer. The other drugs, interestingly enough, you know, when they ranked them, clozapine wasn't number 1 in terms of its effect on positive symptoms. I don't believe that actually, but it was number 2 out of 27 or whatever. But it was not a great study in that regard. But nevertheless, the D2, they all kind of work. They block D2, and D2 is for motor, but it's also for the hallucinations, the delusions, the false salience. It calms all that down. Clozapine's really unique, and so all the other drugs, they have to bind about 60 to 80% is what they shoot for. That's the range. If you get above 80% binding, everyone becomes stiff as a board. Okay? Clozapine does bind D2. But it only usually binds about 40%. It's very different, and it flits on and off. So the fact that and D2 is also important for joy, along with D1 and D4. So people can experience joy. It's important for cognition. The other drugs, they tend to worsen what we call the negative symptoms, the cognitive symptoms. So you get what we call good enough. They're in the basement playing video games. They're not trying to kill themselves or anyone else, usually. And by the way, clozapine's also the only drug for this reason that has the indication, the only drug for suicide prevention. And compared to all the other drugs on whole, except for olanzapine, where it's 25% reduction, compared to all the other drugs that we have in the US, it's an 85% or so reduction in suicide. And you can see why that might be, because if you can think, you can reason, you can start to not be socially isolated, you could start to work with other people. Now, it also works on other pathways, and I'll make it short. The glutamate pathway, and it's balanced with another neurotransmitter called GABA, and it has interactions there, which none of the other drugs do, and also has more distinct interactions also with serotonin pathway. And more importantly, and this is the last one I'll do right now because I can keep going, because we know a lot of its mechanisms. We don't know what's more important. And for any one individual, that aspect, one aspect may be more important for that individual than someone else, which is also why it works better. Because all the other drugs are all doing D2. But what it does is it modulates these cells in your brain called microglia. Now, the microglia are really important. This is why Aaron Judge won the batting title. I'll explain. So, as you do something and you practice something, you have a competitive, what's called pruning of the brain. So that, let's say, Aaron Judge would always strike out on the low outside pitch. He was a sucker for sliders. And they knew that. And he would really strike. But he batting practice time and time again not to go for the outside slider. So his brain remodeled with the help of the microglia, eliminating those pathways that made him swing and allowing the pathways to grow that made him wait for his pitch. Same thing happens in our kids' brains, except with schizophrenia. There's one gene that overexpresses something called the complement, which is how these cells will identify cells or neurons and axons and dendrites, the parts of the cells that need to be removed. Those microglia are overactive in psychotic illnesses. And with stress and dopamine excess, they're worsened. Clozapine distinctly downgrades those microglia and lets them do their job as they're supposed to, as opposed to degrading pathways that you want. It helps them maintain pathways that you want and continue to allow them to grow. Want one more mechanism?
Let me go on to the next question.
It also.
Wait, we have many questions.
I mean,
So-
but it's distinctly, it's a unique drug.
He's clearly passionate.
Oh, because we keep finding out more.
Yes. I'm going to take one from the call. So, yeah, thank you, Sarah, for the question.
It's just a different drug. It really is. It's so neat.
From Nancy Claire Laird on the call. Does schizophrenia impact cognitive deficits, and can clozapine improve cognitive deficits over time? I mean, the answer is yes.
Yes.
Okay.
No, do I need to say more?
No. Anyone else in the room? I think.
Just on other medications, I guess
Oh, yeah.
Cobenfy's been out for a year or so now.
So that's another
Sure.
mechanism.
What have you seen from that? And have you had any families or patients that have wanted to try Cobenfy?
Oh, yes. So, where did Cobenfy come from? Cobenfy's been is two drugs. It's xanomeline and it's trospium. Xanomeline is the active drug that gets into the central nervous system. Trospium is to control the side effects. Where did xanomeline come from? It came from the action of clozapine. It was known that there were effects of clozapine that, were muscarinic. And so they tried to say, why does clozapine work? We'll just grab on and do the M1, M4 and see how it goes. They tried it first with Alzheimer's, and they tried it then with schizophrenia. This is 1999, 2005. And then finally, they said, this drug's intolerable unless we mitigate some of the peripheral side effects. And that's where trospium came in. So they're balancing out cholinergic and anticholinergic. So to answer your question, clozapine is what's called the xanomeline's an M1, M4. I forget how many, I think there's 7 muscarinic receptors. Yeah, 7 muscarinic receptors. And M1 is primarily the prefrontal cortex, where it's elsewhere, but primarily. And M4 is in your striatum. So M1 works via the glutamate GABA pathway to modulate dopamine and increase dopamine in the prefrontal cortex. M4, interestingly enough, downregulates dopamine in your limbic system, which is the striatum. We use the striatum now because the limbic system isn't actually probably where psychosis happens. It's really in the striatum, in that whole area. So using Cobenfy with clozapine is a little tricky because, and I'm trying it in some of the kids that I have not gotten the responses to. But we don't know.
Adjunctively. We're using it
Adjunctively.
largely
It's only adjunctively. In terms of treatment effects, it is nowhere near as effective as clozapine. So, you remember the name of the studies? It doesn't matter. So the original study was the two 5-week trials that went out there, and they looked at kids that went into the hospital and that got approved. They were taken off of their antipsychotics, and then they were given a placebo versus Cobenfy. Well, kids that were admitted for psychosis, having their antipsychotic removed, if this drug didn't work then, it would never work because they were at their worst. But what's interesting, and they got approval for this, if you look at how well these kids did, none of them had really great outcomes. They were better. And if you looked at the treatment model and you looked at the treatment effect, they use these indexes in psychiatry to look for improvement, positive and negative what system score, or I forget what the SS is. I forget. But they look at these things, and that's how they determine that it worked. But when you also looked at it and you looked at the total scores, they were not terribly well. So we think, and we're not sure yet, because I've only got about a dozen kids on these, and it's very low doses. One, we don't know how much to add because we already have M1, M4 from the clozapine. And by the way, the M4 is the norclozapine primarily. That's the metabolite of the clozapine. So we're adding more to the system, and everyone's going to be different. Yeah, for the negative, and it's all for the negative symptoms. Now, kids, unfortunately, we have about 7,000. 7,000 kids on our, or 8,000 now, people on our the Team Daniel Facebook page, and some people have come off of clozapine and on to Cobenfy. Every single one of those that I know of has deteriorated.
Oh, that's big.
All right, every single one, and it's going on now, unfortunately, close to a dozen kids, and we strongly discourage that, and that makes sense. What we do know is, like an insulin-dependent diabetic, you're basically clozapine dependent. We know that clozapine, at least as things stand, unless we come up with something better, is a lifelong drug. Sounds terrible, but what's terrible is not treating a psychotic disorder. It's not so terrible, and I can say that from personal experience. Daniel in March will make 18 years on clozapine. Wouldn't trade a day.
Thank you.
All right.
Okay. We'll take one from the call. So could you talk about the importance of diet?
Oh, you sure?
Sorry.
Well, this is really, I know the data. This is really, it's fascinating. So there's, God, what's his name? Matthew Bernstein and the other guy, what's his name? The keto diet, Palmer. Palmer, right? Yeah. So the keto diets for the brains seem to be, at least with seizure disorders, really important. And there's starting to be some information that they may help with psychotic disorders as well. And I've talked to both Matthew Bernstein and Palmer. What they're saying, though, is metabolic health is what they're shooting for. So if you think about it, anything you do that will improve your overall metabolic health also improves the metabolic health of your neurons, your axons, all the microglia. There's a million different cell types in your brain. It's not only neurons and astrocytes, but it just makes it Yeah, well, I'll go on. You can't just treat. Our contention is the vast majority of people will not respond to a diet to treat your psychotic disorder. Having said that, I just met a woman who was an influencer by the name of Lauren, I'm blocking her last name, who's part of my board, who was on a very low dose of Latuda. It just shows you the heterogeneity of the illness. Came off the Latuda, who's been stable for 2 years on a keto diet. Would I tell you to do that in this setting? Absolutely not. And I find, and I've also found because I've worked with the Ellenhorn people, they tend to overvalue the diet and its effect. And what they do is then they try to taper down our clozapine. And that's led to some problems in some people. So diet is critically important. One thing nice about the diet is once the kids are well enough, they can participate with the diet. So I usually recommend a Mediterranean diet. The keto diet's not bad. The problem with the keto diet is a lot of the kids won't eat a lot of vegetables. And if you don't have a lot of soluble vegetables, or soluble fiber that is, and eating a diet rich in fruits and all the rest, you're gonna run into problems worse than constipation, and that's a problem.
But in general, deprescribing in favor of a keto diet, we've rarely seen it work. There's potential in like pretty low grade psychotic disorders for it to work, possibly, but that's more of a myth.
But I have an intellectual curiosity about it, and it makes sense. And also it goes on to a guy in Canada, Roger McIntyre, who now realizes that the GLP-1s, the Ozempics and the Trulicities and the Mounjaros, the Zepbounds, have a very similar effect to the diet in that they're improving the metabolic health. And what's happening is you're starting to see improvements in negative and positive symptoms just on the basis of these medications. So in a way, you're getting the same effect as with diet. But diet and exercise, what's the one thing that always works? Exercise. No one's asked me about exercise. Exercise is a great mood stabilizer. I expect all of you to sign up for my half marathon in Disney.
I've been trying to understand to the best I can, and I have a naive question. But does it mean that the clozapine can be used to replace the other psychotropic meds, or in addition to what is in my case, I spoke to you, Dr.
What's my name? Just Dr. Al.
When I'm nervous, I forgot what to say. So we spoke this evening, the medications, so does it mean that it could be replaced or in addition?
Well, your son's on Abilify, and we always say there are certain drugs that play well with clozapine. And when we start out with someone, I think your son's on injectable, correct?
No,
just oral meds? We would leave that initially as what is typical. Our approach is we slowly increase the clozapine. We're going to, over time, get to a certain level, usually 50, 100 milligrams, when we're starting to see something with the clozapine. And then we'll slowly decrease the other drug. And we try to diminish it. My son, same thing. How many years it took me to get him off the Abilify? 3 years. It took me 3 years to finally get him completely off of the Abilify.
But on top of Abilify, the other ones.
Yeah, but Abilify plays well with clozapine. So they're partial. Oh, well, the Depakote, what we do is we do usually one drug at a time. And it would probably be the Abilify we would go after to a certain level. I don't know how much he's on. Let's say he's on 20 milligrams. We would try to get that down much lower as we go up on the clozapine. Okay? Then we would go after the Depakote, for instance. This whole time, we don't like Ativan or Klonopin. Benzodiazepines are these incredibly effective drugs for the short term. They really work. But what often gets forgotten is the worst outcomes are for people on long-term benzodiazepines. There's increased suicide, there's decreased recovery, there's decreased cognition. Our goal is always to try to get rid of them. And yet be careful, because some of our kids have had the worst positive symptoms, which is something called catatonia. You know, where they really are so sick that they're frozen. Have you guys, anyone in here has had a kid with catatonia? Yeah, it's really quite scary, you know, where you just get fixed. I mean, at the very worst, there's degrees of catatonia. And with that, you need the benzodiazepines until the clozapine. Clozapine in psychosis with catatonia will work because it does work on that receptor system, but you have to be really careful and, again, slow titration off.
All right. Next, I'm going to take the next question online. So it's actually about clozapine. So does clozapine help with delusions that are possibly fixed? Kano says, thank you for all the help, all you do.
Yes, absolutely. However, I do think delusions are sort of the last positive symptom to disappear, even with clozapine. It's true with the other antipsychotics as well, but those are, you know, the toughest positive symptoms to treat.
Oh, without a question, you know, delusion is a fixed false belief. And all of our kids, this brings us back to anosognosia. So anosognosia, everyone always thinks of that as just being the unawareness of illness. But it's more than that. It really defines their whole thought process. So when you have an idea in your head and it's fixed, you tend to overvalue that idea. And you're not going to listen to outside influences. And why is that? Because the way the brain works, in people with psychotic disorders, they often have perceptual difficulties and they have processing problems getting that information in. And the quickest and easiest information they can get is self-derived. So a false belief tends to feed upon itself until over time you whittle away at it. And this is where the cognitive behavioral therapy could be effective. You have to get them well enough so they can participate. So what we call is cognitive behavioral therapy that is psychosis informed. You just chip away at the delusional belief. As cognition gets better, I call this top-down control of psychosis, and they can think it through. Their ability to process also gets better. They can take in more extraneous information from the outside, and they start to be able to, what we call metacognition, be able to think accurately about their own thoughts. So delusions can get better, but as part of that ease protocol, the S, slow.
We'll take one more question from the room and then one more from the call, which is Jody's question that's next. Anyone else in the room with questions?
Since AI is the hot topic, are you seeing any cases of worsening psychosis by a lot of use of a chatbot and sort of developing a relationship with the chatbot, which they can reinforce your thinking?
I have not personally. I mean, I've read about it, as has everyone else, but I haven't yet seen it worsen psychosis or cause psychosis or other severe mental illness, but
Makes sense that it would, doesn't it? But we don't know.
We also have folks from Mount Sinai's Blau Center in the back, so if you want to learn more about AI and the serious mental illness, they have a table with flyers actually right over there. Great segue. Okay, last question then from Jody on the call. As a caregiver and therapist, I'd like to know some of the key points to discuss with a doctor at Pilgrim Psychiatrist Long-Term Institution about retrialing my sister on clozapine now that she is under their care and able to be monitored for a longer time under medical care. They have been resistant without explanation. She is highly treatment resistant.
Yeah.
So I guess general talking points that
Yeah,
maybe everyone can learn from.
We've done pretty well. Not well enough at OMH, Office of Mental Health Site in Pilgrim State's one of those big Office of Mental Health sites. So 12 years ago, Lloyd Setter, Jake Carruthers, primarily, and me peripherally, started something called the clozapine, considering clozapine. And at that point, we went, and we were very proud. In the first year, we went from 1.8% to 2.2% usage in the state sites. Well, it's continued. It's up to 29% now. So it's a little surprising that Pilgrim State is still so resistant. I've had multiple people at Pilgrim State. It's one of the first places I talked about clozapine there. You just have to persist. You know, it could be that your loved one's a little bit older and they're just afraid of the side effects and managing that. Could be that I don't know if she got taken off because of a side effect, a fear of neutropenia. You can be re-challenged with neutropenia, and if you go very slowly, the literature success rate is well into the high 70s, if not low 80%. I'm 6 for 6 personally. I go extremely slowly when re-challenging people. She could have had what they could have considered, you know, a myocarditis, which often is misinterpreted because they'll have a resting tachycardia. I don't know why they're not doing it. So what you want to tell them is
Titrate slowly.
yeah, go slow.
Titrate slowly, and also I would phrase her concerns as questions, because I've found as an NP that MDs tend to respond better and more openly when you phrase your concerns as questions.
Why not consider it? And you know, and it's an initiative. It's an initiative now around the world. Really, you know, just talking earlier to someone, I said, look, when I go to international meetings, it's not like I go a lot. It'll be the second one come April, because they only do it every other year. But everywhere else around the world, they're really pushing clozapine in a real big way. And you know, we're just a little slow on the uptake. You know, when Freud came to the U.S., we really embraced Freud, and we're still suffering the consequences of that. Freud never liked to take care of people with psychosis. My dad was a Freudian coming out of, you know, my dad was a psychoanalyst, but he learned over time that there's a lot wrong with Freud, and certainly with psychosis. But the U.S. kind of got stuck in that, and a lot of our older psychiatrists don't embrace what is possible. There's a tremendous nihilism, and this is one of the primary reasons in the U.S. There's just this belief that the kids can't get better, and it's very self-fulfilling. If you keep using the same old, excuse my language, shit, you're going to get shit, and it's got to stop, and you got to persist. That's all I have to say. You have to really, and what's coming out, a little self-promoting here, is the 5th edition of Meaningful Recovery from Schizophrenia and Serious Mental Illness with Psychosis. So, you know, when Jonathan Meyer came out with the clozapine handbook, he said, yours is nice, your little 70-page section, but I have a 150-page section. So now I have a 290-page section. So he said he's going to get a new edition also coming out. So we just keep, but it's very well referenced, and it'll be out in the next month or two. So look for that. And there's a lot of information there. Feel free to share it with your treating psychiatrist. The data is just overwhelming. You just have to be willing to do the work and not be nihilistic. You know, think, again, what are you coming away from this thing with? What's the word I want? Thank you.